Great. Hi, everybody. Great to be here. Is this okay, Judy? Judy's my sound check. So I'm really delighted to be here, and I must admit I love the title of this workshop, Counting What Counts. And some of you know I always end my talks with a quote widely attributed to Einstein, although actually quite debatable as to whether he actually said it or not, which is that not everything that counts can be counted, and not everything that can be counted counts. And I think that really sums up where we are oh so well. We are still transitioning, I think, between the world of counting a whole lot of stuff, because it's easy to count, and not yet counting the stuff we really, really, really want to count that I think ultimately becomes the blueprint we heard so elegantly described by Craig. I was given the task of kind of staying at the measurement level, not surprisingly, being the measurement geek, I think, officially on the panel. And really thinking about, as we were talking with Rob in our pre-call, what are the trade-offs? Really beginning to understand the trade-offs as we move from a system that's primarily grounded in healthcare quality to really beginning to think about moving towards population health. What do we lose? What do we gain? And how do we make sure that at the end of it, we come out where we want to be? What are those data challenges and methods? And very nice handoff from me towards Kevin to answer the tough stuff. But also this really important issue of the core issue of alignment. It goes way beyond the measures. It's really about alignment. It's alignment at every level. It's alignment across states, within systems, and more on that to come. And then lastly, we'll touch on this issue of how a core set relates to disparities in subpopulations. I always get very anxious when disparities is left to be cross-cutting in a way that lets it to be somewhat invisible from frameworks. When I led the first National Healthcare Disparities Report at AHRQ, it was very intentional that we took all the quality measures in the National Quality Report and stratified them to begin to see disparities. And I want to make sure we don't lose sight of that, or the critical role of subpopulations as we move towards population health. So a few thoughts about core measures. Could not agree more. That is the right time. I can't think of a better time, actually, than now to say it is time for core measures. People are exhausted by the cacophony of measurement in a way I've never seen it before. I think, as we've been pushing on harmonization and alignment for quite a while at the National Quality Forum, there actually seems to be some wind at our back of people saying, we've had enough. Can we actually move to alignment? And that is a sea change, I think, from what we've seen. We are also, I think, truly moving, we hope, those core measures will be the measures that matter, the ones that matter to patients, the ones that matter to clinicians, frankly, and all of us involved in the broader healthcare system. And I think we heard a lot of that at the workshop, that we should be moving to the outcomes that matter, the ones that are really the ones that will move our needle. Increasingly patient-focused, patient-report outcomes, we hope, really thinking about it, an important piece, I think, for Kevin and all of us in this transition to the electronic data infrastructures. How do we capture the voice of the patient and their families through the use of these new electronic infrastructures in a way we've never been able to do it before? We need care. We need measures that reflect what care really is, which is not episodic, it's continuous. And we need to be able to have that continuity and that longitudinality to be able to capture that. And certainly we can't capture that currently in most of our measurement systems at all. We still have this key challenge of finding that balance, though, I think, between clinical care and population health. There's a lot of discussion at the workshop. Let's just go for the big global health composite in the sky, and it'll work for everything. And yet we know, but yet at some level, we know we still need the specific measures to drive improvement. I thought Craig really described it well. Of course, we're not abandoning the rest of it, but the core measures should be what drive us moving forward in a way that I think we've not done it before. And being able to think about how we drive those measures, particularly on cost, population health, and healthcare quality at all levels, and that I think is a critical issue for us, and for those of us who live in the data measurement world, a real challenge as well. It's very difficult to actually do that yet. And we want to make sure, I think, as they said beautifully at the workshop, these are meaningful, important, and comprehensive, and I hope the upcoming work of the IOM will really capture those three words, because I thought that was really elegantly stated. I think we want to make sure that harmonization and alignment remain core to whatever we do here. It is really time to avoid the unnecessary duplication and burden out there. There is truly a tsunami of measures, as I talked about at the workshop, of slightly different tweaks of measures that you get from multiple different entities in a way that not only don't allow you to see the full patient care that you're providing or allow a patient to see what their care looks like, but actually also erode the trust of clinicians who then don't believe what they receive in a way that is really not helpful either. We need to increasingly think about how we add value without adding burden. And I think those are challenges as well around standardization. We want to get to that standardized set of measures and that beautiful blueprint that gets us to the standardized data elements that makes this thing work. But at the same time, how do we do that and not lose innovation and not lose what's great about people going to the next level of the harder set of measures that we know don't yet exist anywhere in our dreams yet of electronic health records, where we hope they will be, but they're just not there yet. I think we want to think again about this issue of measures at different levels of measurement and how closely related they actually need to be. We often say we want to harmonize. We want to harmonize on the science and the numerator. We have to allow those denominators to flex up and flex down, but at the same time standardize enough that we're not looking at measurement noise that people don't believe, but we're actually looking at true differences in the population. Many challenges, of course, on the data side. You'll hear a lot of that certainly from Kevin. But just interestingly enough, I came this morning from precepting at GW and got one of these little reports you get from the health plans of my patient out of compliance 2 years ago with flu vaccine. Again, this current environment, the core measures we move forward to cannot continue to have me sent a piece of paper by a health plan or showing me a patient 2 years out of date, not value added in the way that drives improvement, since measurement is not just about measurement. It's really the end game. It's truly about improvement. And you totally stole my thunder, Craig. I completely think we have to make sure the EHRs capture the data elements we want and the way we need it for the core set, and that should be our driving vision going forward. We've got to also think about all this growth in registries and how registries connect back to these core measures and this core data set. And I guess if I sort of summed it up, I think the measures need to evolve to meet the new infrastructure, but the new infrastructure needs to evolve to meet the needs of the core set we want, not just the core set of measures that everybody can measure right now, but where I think we want to go. And I think we also have to have measures have to move into this space of continuous quality improvement as well. We need to find out what works, find out what doesn't work, get rid of the ones that are adding burden and no value, and just move on. So a few final thoughts on pop health and costs, and I'll wrap up. So the key things I hope moving forward for the new group to kind of take the next deep dive here is definitions really matter. We need to get to some really core, understandable definitions of things like population health, cost, value, affordability, and I think this is what IOM is so incredibly good at doing. The other thing is denominators matter, and you talked about the tyranny of the now. I actually talk about the tyranny of the denominator. We have a lot of measures that were built on a platform of assuming you had to be seen twice in a given year to have your blood pressure in control. We've got to get out of that box, really start thinking about a population, a responsibility for a population. The measures have to follow that. We also need to, as I mentioned earlier, think about how we get at the subpopulations and disparities, and a core piece of that is looking at things beyond healthcare. It was an elegant presentation at the meeting, somebody from David Kindick's staff who showed the model, and again, reminding ourselves only 20% of the whole variation in health is due to health care. So much of it is about social determinants and other issues, and we've got to think about how we get those measures standardized in a way we can all use them. And I think a great challenge for us moving forward is to start standardizing all of our federal data sets of how we ask those questions about smoking and alcohol and weight and all the key issues plaguing our nation, and actually make that the driving force to how we measure at the clinical level for those core data sets. Costs, lastly, I think there is so much happening here that we need to understand. We're in the middle of this process right now at NQF. Really, this issue of standardized cost prices, all of these things, again, require precision and definitions that people can really rally around, so we don't get caught in comparing things that don't really add value here. Huge challenges with risk adjustment as we get to these big picture outcomes, and we shouldn't assume these are simple issues. We've really got to wrap our arms around them, come together and think about how do we work in an environment where we recognize the fact that different groups use different risk adjusters to accomplish the same aim. And so lastly, on alignment, just because it is sort of the core, I think, of what we want to go to, just a reflection on buying value, which is an initiative Jerry Shea, who's our acting CEO, I think for a couple days more, still as Chris Castle comes on board, has been leading with leading purchasers and employers and health plans to really get at public and private alignment. And I have never really seen before the desire to get there in a way that I think is palpable and very different than it has been in the past, and the idea of working towards a common measure set. And I do think having a common measure set just put in front of them as a straw man has driven this debate in a way that I think was really powerful, in a way that sort of conceptually talking about domains didn't do it as much as putting a list of measures on the table for discussion. And even then, obviously, huge challenges. So lastly, timing is key. Receptor sites, I think, are finally there for this kind of work, and I think that it's the right time to do it. I think we really need to think about the future needs of measurement and the future needs of the data we'll need to support it, not be so grounded in the now. I think we need to keep an eye on what's coming down the pike, what will be the next thing we really want to make sure that measure, because hopefully that's what really will count. Thank you.